Good day, my dear postgraduate students. I shall be continuing with our spree of grossing. And in this class, it will be grossing of the kidney, the tumors, part 1. In this, I shall be concentrating on the normal anatomy, fascia, any congenital anomaly as such, the development. Also, an overview of kidney tumors, the types of surgeries, tumors, and the modes of sampling will be dealt with. When it comes to the classification or categorization, I hit upon this quote. People like to understand and categorize things in order to understand. A very weird situation. The normal anatomy. Always be familiar with the normal. You are going to be thrown innumerable questions by the examiners at the normal stage. I have tried to round off the values as much as possible. 150 grams is the weight, can be a little more or less starting from 135 grams. The dimensions, though not perfect, this is a good logic. 10, half of it is 5, half of it is 2.5 centimeters. 10 into 5 into 2.5 centimeters will be the length, breadth, and the thickness. Corticomedullary differentiation. That is what you people are seeing over here. The pale and the dark areas. And of course, the triangular areas of renal pyramids, you are all familiar with, but maybe there are 8 to 10 in a slice of the renal tissue. And the area in between form the renal columns. The capsule is usually thin and transparent. I can find an underlying shiny renal parenchyma. The pelvic ileal system is intact, and in fact, it will be difficult to find the primary and the secondary calyces. Then you have got a renal sinus in which there will be the evolution of the blood vessels, the entry and the exit, as well as the renal pelvis and the ureter. Around the pelvis, in this region, there can be fat which is called as pelvic fat at the high level. And there is also some other type of fat which I shall be telling you. This is a fantastic picture which I had hit up. Usually the students stumble when they are asked about the coverings of the kidney. Take anyone for example. So this is the kidney over here, and it is surrounded by the perirenal fat, around which there can be a fascia called the R.A.T.S fascia. And still out, you have the pararenal fat. These are the things that we'll have to have in mind. And please note that these are radiological findings. There can be something like the bridging fibers within the fatty tissue. So this is important. The kidney by itself is a retroperitoneal organ, and in front of it I have got the pancreas, and behind it of course is the vertebra, and in between will be the great vessels. This is again a very superb sagittal section of the same. There is a liver on one side, the peritoneal cavity, the kidney, of course, the pyramids have been diagrammatically depicted. There is the renal sinus, the central region out of the pelvis, where there can be fatty tissue. That is why you have got the yellow color. And there will be the pararenal fat also. So there is a perirenal fat and a pararenal fat. There is a fascia that is surrounding it, which is called the Gerota's fascia. This is again Dmitry Gerota, who was the person who has named the fascia. Look at this particular diagram over here. So the kidney again, there is the perirenal fat and then the Gerota's fascia marked in the red, and then there will be the pararenal fat. This we will be having in mind. The development of the kidney arises from the mesonephros or the Wolffian duct. Fundamentally, there are two units to it. One will be the tubulocalyceal system or the pelvic calyceal system, which is developing from the ureteric one. And there is a branching and then a rebranching. Finally, I find the pelvic calyceal system that is being formed. External to it, there can be the stroma as well as the epithelium that is being formed. Epithelium itself has got two components. One will be the vascular one and the other is the tubule which is getting formed. This we shall be roughly having in mind. So remember the Wolffian duct and the mesonephros for the time being. There can be many a congenital anomaly which can be present, which may be kept as a specimen for you in your exam. So in this case, there is an ectopic kidney or a pelvic kidney. In the second diagram, I am finding a horseshoe kidney, and this circumvents the great vessels. Also, there can be a unilateral double kidney with both the ureters on one side, getting connected to the blood vessels. Here there is an aberrant renal artery which kinks on to the ureter, causing a hydroureter locally. A rosette-like one. Probably it is almost a mirror image of the horseshoe kidney. And there can be the aberrant renal artery. Thanks to it, because the renal artery is supposed to be an end artery, and this may be an advantage or a disadvantage. So these are some of the congenital anomalies. We shall have it in our mind. Again, the same picture of it, a horseshoe kidney, then the double ureter on both sides. The abnormalities that you can find in the kidney include aplasia, no development, hypoplasia, underdevelopment, ectopic, there is an external out of the way development, and then many cystic lesions. Coming to the surgeries about which this class is mainly about. There are two basic forms of nephrectomies: partial nephrectomy and radical or total nephrectomy. Only two. So this also can be, it is called a nephron sparing surgery because a good number of nephrons are retained for the functional reason. It can be an open surgery, laparoscopic, or a robotic surgery. Now this is the talk on the fashion of the day. Radical surgery again can be open, laparoscopic, or robotic. Ablative therapies in which the kidney is almost destroyed. Cryotherapy, radiofrequency, etc. And surgery in the case of advanced renal cancer and the removal of metastatic lesions. Though this might not be a complete treatment, it is done for other purposes which is beyond the purview of my talk. Though it is partial, this is more complex to perform. Obviously, you find that there will be enough amount of damage, bleeding, and to make the rest of the kidney functional is an arduous task. Also, you will have to retain the pelvic calyceal system and the blood vessels and the ureter. There can be an ischemia due to clamping. Hemorrhage is a common problem, and this is the more complex procedure. Radical surgery is done for the early stages, T1 and T2. Typically involves the entire affected kidney, and the adrenal is also being removed. Proximal one half of the ureter and the lymph nodes adjacent to the blood vessels are being removed. Whenever I talk about the lymph node in kidney, please remember the hilar lymph nodes, which are more important than elsewhere. The reasons for the renal surgeries can be one, for increasing the diagnosis. Rather, the other way around. There is an increased amount of renal surgeries because of an increased diagnosis and the radio diagnosis. Though the incidence is quite high, and males being nearly 5 times more common victims of renal cancer than women, we find that still the treatment has advanced because of these two reasons. The ablative surgery. When it is complete, no specimen is left behind. Therefore, pathology has got a little role in it. We may not be able to give a histological diagnosis. It can be minimally invasive, as in a cryotherapy or a radiofrequency ablation. Laparoscopic surgery is possible, robotic is possible, and sometimes it is partially hand assisted, percutaneous. What are the advantages of an ablative surgery? Shorter time, less blood loss, no transfusion required, and no operative pain, quick mobilization, shorter stay, etc. Of course, these are all the commercial words in the dictionary of today. Early resumption of normal activities. The disadvantages, however, will be the loss of specimen. We all know what is the value of a specimen and the umpteen number of details we can derive from it. And there is no histological backup. That is why a minimally ablative one is an intermediate form that is being attempted at. Partial, what and why? It is a nephron sparing surgery. The tumor and the surrounding tissue is being removed. Pelvis, ureter, blood vessels are spared, and the cancer has to be less than 4 centimeters in the stages of either T1A or 1B. And 1B will be a little larger, 4 to 7 centimeters. There is another reason also, common sense. The kidney already has got a poor function. The entire kidney cannot be lost. And the patient has got only one kidney. Or there might be lesions in both the kidneys bilaterally. And there is an increased tendency for the patient to develop a renal cancer due to inherited diseases. In all these conditions, you find that a partial nephrectomy is justified. A cryotherapy in which the organ is literally frozen. This is a hand-assisted laparoscopic surgery. The advantage is the entire tumor and the surgery can be visualized on the screen. Though it is not totally robotic, it is hand-assisted. Therefore, still the surgeon has got a feel of the surgery and the mass. Always, for any kidney or any organ as such, this will be a protocol to be followed. The weight measurement of the overall specimen. That means including the fascia and the perirenal fat, and the assessment of the vein, artery, ureter, and nerve. Margins and the tumor and fascia, the capsule, tumor and vein, along with the ureter. It has to be opened longitudinally from the lateral to the medial side. And the veins will have to be cut longitudinally if you suspect a thrombus or an invasion by the tumor. Even otherwise, a cut surface or a cross section downward shape can be derived from the ureter, artery, vein, etc. and all can be mounted en bloc. What are the common types of tumors? And when the discussion in multiple resources or the references I met with, they mention it can be the classical, which is most common, the clear cell type, papillary. There is a photo over here. Chromophobe carcinoma, oncocytoma, spindle cell variant of a carcinoma, and Wilms tumor. So these are the commonest one. Wilms, of course, it occurs in children. And in this, I am able to see a tumor that is well circumscribed, not capsulated. And if I look at it carefully, there are fine excisions that can be made out. Obviously, a papillary carcinoma. Otherwise, if it is going to be cystic with CNMON type of projections, the diagnosis will be quite easy. In a partial nephrectomy, the diseased portion is removed and the pelvis is spared. Whereas in a radical nephrectomy, the complete kidney is being. Look at this one. These are things that we will have to have in mind. There is a tumor in the region of the superior port. There is an invasion of the adrenal. And there is also a nodule over here. Now it can be an independent tumor on its own, an adrenal adenoma, or it can be a metastasis from over here. All said and done, sampling will be very crucial from the tumor and the adjoining tissue. Sometimes it can be multicentric. The distance between the tumors will have to be measured, and there have to be thorough sampling of all. And this is the fat that is surrounding it. Any invasion of the perirenal fat will have to be sampled. Again, look at this one beautifully. There is a renal capsule, and then there is a perirenal fat surrounding which there is a Gerota's fascia. There should be no confusion about it at all. I am finding a tumor that is close to the capsule. Therefore, a sampling of the capsule, the tumor, along with the perirenal fat becomes extremely important. And when there is going to be an invasion of the renal sinus, care should be taken in handling the structures. It can be the renal vein or it can be the ureter lower down. The distance from the surgical margin, it matters. Always it is said, whenever you give multiple bits, the bit that is closest to the surgical margin is of paramount importance. Here in this one, the adrenal is also being sampled and the rest of the renal parenchyma, it is a must that you will have to do it, and also the pelvic region along with the other structures. The rest of the tumor away from the margin also is being sampled along with the adjoining normal kidney. In a case of partial nephrectomy or even a radical nephrectomy, you find that the resected margin, capsular region, should be inked by black. And there is another one, because it is partial, I'm going to cut across the kidney. Therefore, another resected margin which is marked as blue. Because once the bits are given, the orientation becomes difficult. And whether it is partial or a total nephrectomy, it has to be cut from the lateral to the medial, just like bivalving it or separating it, and as slices of a book. In the case of a large tumor, it has to be cut parallelly to permeate enough fixation. And this measurement, as I told you, is important, closest to the surrounding tissue. The gross appearance, size, distance, consistency. Even before opening, it is said that you will have to feel the consistency of the kidney, whether it is firm, soft, cystic, whatsoever. Cut surface, of course, variegation, satellite nodules, nodules that are surrounding the kidney, but distinctly separated. Circumscription or so-called encapsulation, which is not there. Invasion of all the structures and areas of necrosis and hemorrhage. These will have to be described whenever you people have got a specimen. Again, we are all having mounted specimens or formalin tipped specimens which will be uniformly grayish white. But if they are being treated with ethanol, the original color, it is said, may be retrieved. This is a partial nephrectomy. So it is open partial, or sometimes it can be laparoscopic. It is called as a nephron sparing surgery. It can be robotic, and the other one is called as a radical surgery where the entire kidney is being removed. Obviously, this is now the talk of the town. Radical nephrectomy. Many of the things overlap. So I will not be repeating it. So palpation, external examination, inking of the Gerotas with black, then the long axis cut, what is the outer surface, any additional tumor on the cut surface, what is the measurement, what is the gross appearance, color, etc. Pelvic calyceal system. Measure the distance between the tumors. So this is important, whether it is multicentric or one is going to be a metastasis of the other. Perinephric and parapelvic fat. And the suprarenal or the adrenals. Lymph mainly in the hilar region. Look at this. A bosselated lesion, obviously not difficult to diagnose, but what will be important will be this. When it is not being obviously involved, they are taking a cut surface of all the structures. But if there is going to be a suspicion of a spread, be it a thrombus or a tumor invasion, then it has to be slit longitudinally. And the addition to the vessel wall or the ureter will have to be confirmed. And the way the bits are being given, I need not be going into it. The tumor along with the normal tissue, the renal tissue, the pyramid, etc. And sometimes the adrenal over here. And this area has got absolutely no relation to the tumor, yet it has to be sampled. What are the steps? This we have already mentioned, it is only a repetition. So I would like you people to deliberately go through it, and all the things have been covered already. Photographing of the section. This is extremely important. We always expect the postgraduates to draw a diagram, but still better will be an immediate photograph. Nothing will be equal to the original picture of it. In fact, the surgeons are requested not to slit the specimen and examine it in the theatre on their own. Serial sectioning can be required for a large tumor or additional details. Bits. Measurement and bits go hand in hand. That is what I said. So, what you will have to give the bits from will be the renal vein, a donut-like one, multiple blocks from the tumor and fascia nearest to the capsule, other structures such as the pelvic fat, pelvic calyceal system, fascia, additional tumors, uninvolved parenchyma, and the adrenals. Now, when you measure each of these, obviously there will have to be bits from each of them. Therefore, I have put this line deliberately. Measurement and bits go hand in hand. So, look for all these structures. The ureter, the blood vessels, and the tumor in different areas, penetration into a vein, lymph nodes at the hilum, gyrotous fascia, normal kidney. These are the salient points from where sections should be taken. So, again a repetition. So, the invasion into the perinephric and the renal sinus will be of great importance in staging and deciding the prognosis. What are these two tumors? I hope you are able to appreciate the difference. In one, I am finding a well circumscribed, not capsulated, but it has got yellowish discoloration, and then there are areas of hemorrhage that are seen over here. So it is a renal cell carcinoma. And in this one, it is around the pelvic calyceal system that I'm able to see something. And this region is having somewhat excrescences. Probably it is a urothelial carcinoma. I would like you people to kindly differentiate and explain. For the time being, I will say that this particular tumor is well circumscribed and it has got a localized depression in the center. It is somewhat mahogany brown in color and there is a radial pull towards the center of it. Whereas in this one, this is a kidney, this is a pararenal fat or the perirenal fat, and then I find that there are multiple nodules. With this one, what the author says is the yellowish color is clearly in favor of a renal cell carcinoma because of the amount of fat that it can contain. So this is a beautiful table. I would like you people to kindly by heart. So there can be a clear cell type, which is most common, and you will have to look for the solid and the cystic areas and hemorrhage and necrosis. Papillary is usually unencapsulated. It is tan in color. Again, the same thing. Chromophobe type, it is well circumscribed and tan in color. So it is possible that this is either a chromophobe carcinoma or an oncocytoma, which is mahogany brown in color. Sarcomatoid tumors, on the contrary, will be firm, solid, and somewhat whitish. And in the medullary and the interstitium, we will have to look for small lesions within the medulla as well. The significance of crossing. The hardest thing in life is to learn which bridge to cross and which bridge to burn. A nice quote over here. This is not crossing. Maybe it is crossing also and it is grossing also. See, I have already mentioned the importance of the cut surface and the serial sections. Because of this, they are able to find out how close the tumor is to the capsule or to the fascia, which may not be deciphered when it is longitudinally cut. So such is the importance of serial cross sections. And I find that in some areas it is almost showing an invasion, whereas in another one it is quite far away. And in this, microscopically, it is far, far away from the surrounding tissue. And ever has it been known that love knows not its own depth until the hour of separation. So probably only when we are separated, we know the pain of love. And however, this word separation was what I was interested in, and I hit upon this Khalil Gibran, a very famous author. Look at this particular one. The tumor is well circumscribed over here, and the rest of the kidney appears almost free of it. But then there are multiple nodules, areas of hemorrhage and necrosis, yellowish areas also. And some of it is bulging above the cut surface. Renal cell carcinoma is yellow in color in this region. Otherwise, it can be red because of hemorrhage, black because of necrosis. Thanks to pathology outlines for this superb picture. So, you people are supposed to comment on the nodules, the invasion, variegation, the normal kidney, pelvic ileal system, corticomedullary differentiation, the measurement, consistency, etc. Look at this yet again. There is a normal tumor over here. There is another normal kidney over here and a tumor elsewhere. There is a definite plane of cleavage between it. This is what I call as separation. And this is being very well picked up by the radiologist. Also, the stellate scar is clearly made out over here. And this helps the surgeon to very confidently go in for a simple nephrectomy or a partial nephrectomy with a part of the kidney and the tumor, and they are not wrong in their surgery or diagnosis. The pathologist has to only fill the last pages. The plane, and the pain of separation. Separation is the absence of love, and love is the absence of separation. Coming towards the end of it, this is something that is totally different, the Wilms tumor. But then it has got certain peculiarities which I wanted to highlight. It is a pediatric tumor. Obviously, the child will be much younger, 1 to 3 years or so in age. The bits are being given as in the other tumors. So there is a tumor along with the capsule that is being given as well as the perinephric fat. The R.A.T.S fascia, if involved, should be included. Now, what is more important in the case of pediatric tumor will be a chromosomal analysis. 1. Flow cytometry. Hence, the bits will have to be preserved for these as well. So they are the various bits over here. I need not go into it. The hilar fat as well as the surrounding normal tissue, all are being included in the process. This again, the chromosomal and the molecular analysis are important for distinguishing, because once we are going to get small round cells, maybe with some immature elements. And these are the list of tumors that should be borne in mind. A Wilms tumor, neuroblastoma, rhabdomyosarcoma, Ewing's, Burkitt's, leukemia, other germ cell tumors, synovial sarcoma, and so on. So for all this, it is required. It is a beautiful list that we can buy back. Always, as in the other cases, photograph. Frozen section may be required for deciphering the margins. And sometimes it can be bilateral, in which case partial surgeries are needed. And similarly, when the patient has already undergone a chemotherapy, a partial surgery, a nephron sparing surgery can be considered. Thanks to Children Oncology Group for the wonderful reference that they had given. So these are the various things. And apart from other things, you will have to look for this nephrogenic risk that might persist even after chemotherapy. The weight, slice, other things are all almost the same. Photography, etc. For special studies, you will have to do. Sometimes touch preparations and scrap preparations may be done. And after chemotherapy, you will have to either do the snap freeze of the normal kidney if sufficient tissue is present. Photograph. Paper towels. This is something of a good habit that we always do because the kidney is almost a solid organ which prevents percolation of the fixative. Therefore, paper towels are inserted in between the slices, which will help in the capillary action of seepage of the fixative. Nephrogenic risk often persists even after chemotherapy, and this will have to be borne in mind for recurrence. The references include all these, the grossing, etc., pathology outlines, as well as the American Journal of Surgical Pathology and the Royal College of Pathologists, Australia. Our separation of each other is an optical illusion of consciousness. Nobody can understand this man with the highest IQ, Albert Einstein. Our separation of each other is an optical illusion of consciousness. God alone knows what he means, but I hope that you people have understood the topic. Thank you.